Morning, everyone. In today's foot module, we had a talk from respected Dr. Vrisha Madhuri. Unfortunately, she had some circumstances that she could not deliver this talk today, and maybe at a later date she could be able to do it. But we have a couple of interesting cases to be presented. And along with me, Dr. Anil Agarwal is there. So we'll try to moderate and share our experience and how we would do things. So we have two key interesting cases today. One is from Dr. Chinmay Sangole, who Chinmay is from Amravati, and he's soon heading to Hospital Sick Children for his further fellowship. And then Dr. Tashween from Ortho Kids, he would also present one interesting CVT case. So, Chinmay, you can start sharing your screen.
Yes, sir. So my screen is visible. Hello.
Yes.
My screen is visible.
Yes, it's visible.
Good morning, everyone. I'm Dr. Chinmay. I'm presenting a casting technique, and it's a short-term follow-up in idiopathic congenital vertical talus. So, a newborn was presented to me with a both foot deformity. On careful clinical examination, he's having a clubfoot on the right side. On the left side, he's having this type of deformity. His hip, spine, and upper limb examination were normal. To better assess the deformity on the opposite side, I divided the foot into 3 segments and tried to identify each segment. So in a hind foot, he's having an equine valgus. Mid foot, there was a dorsiflexion. In a forefoot, there is a foot is abducted and dorsiflex. If we look at this deformity, it looks like a rocker bottom foot, which comes with the congenital vertical talus. To further confirm my diagnosis, I went away with and take the help of X-rays. In the X-ray, I took a lateral view in a plantar flexion and dorsiflexion, and the orientation of talus is more of a vertical. So it is not changing the position, so it comes under as a vertical talus. But what is more important, we get from these lateral views in plantar flexion and dorsiflexion, are we able to explain the prognosis and natural history? So there was a paper which was published in 1970, which talks about the prognosis and natural history of this type of vertical talus. They divided the vertical talus into 2 types with reference to the calcaneocuboid subluxation or dislocation. So how to define it into the X-rays? So whenever there is a calcaneocuboid subluxation, calcaneum will not go into much of the plantar flexion. But whenever there is a much of a plantar flexion of the calcaneum and more vertical orientation of talus, this lined up into type 2 Coleman vertical talus, which having a suboptimal result as compared to the type 1, in which there is only calcaneocuboid subluxation. So this is also important while we explaining to the parents about the natural.
Chinmay, can you come again? Yes. So what things you will see in a lateral stress X-rays? Now you have done stress dorsiflexion and stress plantar flexion. So which angle you would see?
I'll see for the Tamba first, and I'll look for the vertical talus orientation. We will be moving with the plantar flexion and dorsiflexion. If it is staying more of a vertical, then it will end up into the vertical talus.
So here, on the right side is the most plantar flexion view. Is
Yes.
that right?
Yes, sir, yes.
Yeah. So you see the first metatarsal and talus axis, and ideally that should coincide, yeah? And if it's an oblique talus, then on a plantar flexion view, the talar axis would align with the first metatarsal axis.
Yes.
And second thing which you would like to see is whether calcaneum is fixed or not.
Yes.
So the distance between the posterior malleolus and the calcaneus should, if it is not changing even in dorsiflexion view, that means there is an equinus contracture and calcaneum is fixed. Now the third parameter you said calcaneocuboid. So can you explain it again?
So there was a paper by Coleman in 1970 where he talked about the calcaneocuboid subluxation or calcaneocuboid dislocation. What happened into this is that there is a more fixed or rigid deformity whenever there is a calcaneocuboid dislocation. And this type of vertical talus take more time to correct surgically or as well as your casting wise techniques.
How would you find out calcaneocuboid dislocation or subluxation radiologically?
On the radio, they define that classification into the older population group at the age of 3 or 4 years. But on looking at the X-ray, the calcaneum orientation is go into more plantar flexions in calcaneocuboid dislocation.
See, there's an infant's
So
X-ray. We don't see cuboid is not ossified, right? So can
yes,
we diagnose in this age group in infant?
It's only an interpretation with reference to calcaneum, sir. Because what I see on their X-ray, their vertical talus, sorry, the calcaneum orientation is more in a plantar flexion and rigid. But this deformity is partially correctable, so it comes under a type 1. Not carefully, not confirmatory, we have defined the calcaneocuboid subluxation or dislocation in this type. But of course, in the older age group, we can define that.
Yeah, so this is bit dicey because for this first metatarsal vertical, talus we have reference and as you said, but for calcaneocuboid we cannot compare with the fifth metatarsal, Anyways, but this needs to be read. Yeah, please go ahead.
So after confirming this diagnosis of congenital vertical talus, so there was a paper which was published in 2022 which talks about the algorithmic approach for vertical talus. As we all know, the whatever our traditional teaching is that you do a opposite maneuver of a club foot to treat this vertical talus, my conservative manner. But what is more important here is the soft tissue stretching. So what we are doing into this is a dorsal soft tissue stretch. What we are doing, we place our finger, the index finger over the plantar talar head and thumb over the sinus tarsi, and we give a gentle traction to the sinus tarsi and with the fulcrum over the plantar talar head to push it inside. What this causes, it will cause the dorsal structure to get stretched out. And if you closely look into this small lateral view, the head is readily go inside. If you concentrate on my finger, it's go inside and the talar head is getting reduced. So this maneuver before casting will give you the orientation about the bony landmarks, which are difficult to palpate into the vertical talus because we are not well oriented with the vertical talus because the cases are not so frequently. So before casting, this maneuver will help you to get to orientation about the bony landmarks. Now coming to the casting technique, here the most important aspect is to thumb position and the index finger positions. We have to use both the thumb. What I'm doing in this X-ray with the opposite hand of the with opposite side, I stabilize the sinus tarsi. With my other thumb, I am palpating the dorsal navicular. My index finger is on the plantar aspect of the navicular, and I give a gentle traction to align the navicular to come over the talar head, and at the same time with the index finger I am pushing the talar head above and in a lateral direction, upward in a lateral direction. So whenever this alignment is get, subtalar inversion is attained, we do a plantar flexion at ankle to align all these bony fragment in a line. Once we achieve that, we give a well molded arch medially. So the reduction which we achieve will be maintained, and the talus will be in a place. This is the cast which I had done after the second cast. That's why I'm getting a very much molding over the talar head. If you closely observe my my index finger is always on the talar head, so my reduction will not get reduced. So the maneuver is that the adduction through the midfoot and supination, which will align all the bony fragment in a stellar inversion. And the last maneuver is the plantar flexion of the ankle, and this will give you the alignment to all these bones. If you look at this final positioning of the cast, the well molded medial arch is attained in a plantar flexion, and the arch is giving us a sensation that the talar head is getting reduced. So after the completion of this cast, we have to look for the three parameters that is happening. Real arch is well attained. So this is we should be attained after doing this casting for the vertical talus. Now, after the three casts, as this is the idiopathic vertical talus, I will able to attain the good deformity correction as compared to the pre-operative. The calcaneum is well corrected from equinus to more of a neutral in rotation, a little bit neutral in rotation. The midfoot, which is dorsiflex, is getting corrected, and a forefoot dorsiflex and abduction is getting corrected, and a well-attained medial arch on these photographs. So this is at the 1 month, sorry, 1.5 month after three casts, I attained this correction. Now coming to the bracing protocol, the paper which was published by Dobbs in 2006, where it talk about the bracing protocol, the 15-degree plantar flexion at metatarsal region, which checks the which causes the talus to keep in a position for a longer period of time. We modified or we customized this type of the braces for the children, so the talus will not get dislocated or subluxated into again in vertical talus position. So this is at 5 months of follow-up of the same children. The correction is well maintained in all aspects of the foot, midfoot, hindfoot, and forefoot, and well and maintenance of the children is still in my follow-up. I'll do the X-ray at 6 months and at 9 months. If the reduction is well maintained, I'll continue with the basing protocol. If there is a subluxation or a dislocation, we'll go for the mini open and the or the vertical talus pinning. Thank you, sir.
So thank you, Chinmay. This was nice demonstration. What was not there is a frontal view, you know. Whenever we try and correct CVT, we must produce what you say, a reverse clubfoot kind of position, so that you are trying to invert and you are stretching the lateral structures, the lateral dorsiflexors and peroneal, and then that will bring your navicular over talus. Many a times, in very chubby children with idiopathic vertical talus, it's very difficult to identify the bony landmarks or where the talar head is. So in those cases, what I have tried is to just you create a clubfoot kind of situation. And a good point is you earlier on, you keep the foot in plantar flexion, but eventually once you start seeing that it is getting corrected, you may dorsiflex the foot, keeping the foot in inversion. So that will keep the talonavicular reduction okay. And of course, we need tenotomy in most of those cases. Bracing, giving 15-degree plantar flexion at midfoot, we have not been doing that. We have just been, once it is well corrected, we give the typical clubfoot splints in 15-degree external rotation. Dr. Anil?
Yeah, sir, I would like to comment on two aspects.
Can I ask you a question? How long you would brace these children with idiopathic vertical talus?
I usually brace them for 3 years. Okay, if the treatment is there, but I don't give. I give a basically AFO with a arch and lateral reinforcement and ensure that the lateral border of the brace is straight.
Okay. Now,
but no plantar flexion.
Yes, that's right. Now, this Sujit's question, and Anilji, I'll come to you. We will like to listen to your comments. Just a moment. In couple of my cases, though clinically it looked good, somehow X-rays are still the same with vertical talus. In this scenario, what's the earliest age you do percutaneous mini open procedure? So, let me tell you the history of vertical talus management. That earlier on, and Dr. Anil would agree, that all vertical taluses were given casting in a hope that we have to make brace and we have to operate them near in 6 to 9 months. And then Matt Dobbs' paper came when I was in Sikki's in around 2007-8, and 6, yeah. So earlier in the first paper, they corrected all this with the reverse Ponseti and then percutaneous K wiring. So in his earlier series, his experience, just doing casting was not enough. There are a lot of relapses. And Sujit then came a close K wiring, taking the reference of first metatarsal and talus, and they placed percutaneous wire under anesthesia. So it was and even after doing percutaneous K wiring under image intensifier, they found some of the taluses were down at 1 year follow-up when the navicular start ossifying. Meaning that even the percutaneous reductions and wiring are also not reliable because these midfoot structures are not ossified. And so then came minimally invasive mini open reduction. And so my practice is to start casting. And once I feel that talonavicular reduction is happening, then I will open it and make sure that this navicular is aligning with the talus. And then you put a wire. Now, the problem is for a very young child, if an idiopathic vertical talus presents to us in first few days of life, that means they need an anesthesia in the second month of life. And we need to put a wire across to prevent recurrences. But parents usually do not get agreed to this. So we have to put forward two things, that we have to do this now, or you correct it and put them in a brace. And then we might need a formal mini open reduction at 6 months to 9 months when child is older. Sometimes when it is very mild deformity, you may get away without any wires, probably as in Chinmay's case. But in most of the cases of true vertical talus, we need to put a wire across. So earliest I have done is 1.5 months open. That's my answer. Anil ji, would you differ in that?
Yeah, sir. In my case, looks like a simpler variety or a milder variety. Okay, in most of the cases, the vertical talus is associated with some kind of syndrome, and 70% of them are associated with AMC. Those associated with AMC seldom get reduced by closed methods. They are very rigid
So
feet.
we are talking about simple idiopathic CVT first, and then we'll
So
talk about syndromic.
the problem with CVT is that most of them are not idiopathic, where it is reversed in the idiopathic foot, where more are idiopathic and less are syndromic. So
Yes.
that's the distinguished feature between the vertical talus and the clubfoot. Second thing, I have tried the Dobbs method, but personal experience have been not so great. What happens is that you are able to reduce the joint in idiopathic clubfoot, but over the time, as the child starts walking one over, when you obtain the X-ray, you see that it has reversed back to the original position. Even if you have done a mini open, and ultimately it needs a frank reduction. If the parents are happy with that kind of reduction and the foot looks okay despite the X-ray, we don't do anything. But if the foot looks abnormal, the X-rays are always abnormal. They are never normal. This in Dobbs after 1 year. So if the parents are not happy and the X-rays are also not good and the foot is deformed, we go for frank open reduction. And personal experience, almost 80% of them will require open reduction after Dobbs method.
Okay. So I agree with that point that some of them, they recur in the deformity mainly because of their subtle syndrome or the weakness of plantar flexors and inverters. And so in period of time, parents are not compliant and children will drift away the foot again. So exercises or passive stretching is very important. And at the outset, if you find that there is a syndromic association, you may tell family that we might need to do some definitive procedure at later date. So, so as far as this conservative treatment of idiopathic vertical talus is concerned, the reverse Ponseti technique has been discovered by Matthew Dobbs, and it is successful in many instances when they are idiopathic ones. So Chinmay, you nicely presented. The maneuver was well presented. A simple arch can be given in the brace so that it will keep the foot inverted. And the key point is when you aligning the midfoot to the forefoot, you keep the heel in equinus, and that makes and try to stretch it. So any other question about idiopathic vertical talus? Sometimes the people how would you differentiate a true vertical talus from oblique talus? Chinmay, would you answer that? Because there's a main question fellows usually ask.
Yes, sir, I always
Anyone would take that? How to define an oblique talus? Vikas or who we have? Deepak, Naveen, and there are a lot of OnePluses and a lot of iPhones, but Yash. So my question is, what is oblique talus and how the treatment would differ? Chinmay, batao.
Sir, in oblique talus, on X-ray wise, while doing a plantar flexion, it will get aligned with the first metatarsal. So we can observe that case, but I didn't see any oblique talus in my short term of practice in 1 year. But on X-ray wise, we can define it. It is an oblique talus when it is getting corrected in the plantar flexion.
Right. So what happens is there is a paper now. I forgot the position or the inclination of talus is pure vertical, a bit forward and straight. So there are three angles. So the straight is normal. The one which is oblique, they were terming it as an oblique talus, where the anterolateral structures are very easy to correct. And if they remain like this, only tenotomy would correct the issue. So that's an oblique talus. And the vertical talus, it is fairly vertical in alignment, and it's difficult to correct in the lateral plantar flexion view. Yeah. So the treatment, many a times people try to differ because it's difficult to differentiate. It's because of the flexible arches or it's a real deformity. And you try to wait till the child grows, and if it remains, there is increasing tightness of TA, locked calcaneum, persistent vertical alignment, then you correct it. Right. So as Dr. Anil said, that most of these are syndromic children, and these syndromic patients are real problem. Like I will like Tashween to share his screen now, and let's go on to the another arthrogrypotic child and what problems we faced. Any questions? Then you put it in chat box. Any comment? You raise your hand. We have very passive crowd. No, this is a interactive session, more so when main speaker is not there. So feel free to ask the silliest question you have. Okay, it's not very formal. This thing. Rashmin, we have some sound issues. I think you all are sitting in one room. Yeah, go ahead.
Okay, sir. Good morning. This is an interesting case, and a 5-year-old boy presented with left foot deformity and is a known case of arthrogryposis multiplex congenita, diagnosed to have bilateral congenital dislocation of knee with congenital vertical talus and developmental dysplasia of hip.
So just stop it there. So Dr. Anil, are you there?
Yes, sir.
Yeah. So
Yes, sir.
we usually receive this bag of problems, DDH, vertical talus and dislocation of knee. How do you approach them? How would you start the treatment when they have multiple deformities? Where you focus first, just for the learning of everyone.
So I will usually start with the knee and sometimes it's not vertical talus, sometimes it's club foot.
Yeah.
So to help put a proper cast I would go for the knee. Knee has to be flexed to hold the cast. So my priority is the knee. And when the knee starts correcting, if it is possible in a cast, then I would go for the foot portion and last the hip portion. I usually aim to correct all of them by 9 months. And if required, I'll go for medial open reduction for the hip at the same time. I am treating the foot or any surgery is required for anything.
Yeah. So that's a great approach. And so we need any foot correction, we need the knee in the flexion so that the child does not slip this plaster off. And so we try to do congenital knee dislocation treatment first. Many a times we are not successful in stretching out the quadriceps. And there you might need a percutaneous quadricep tenotomy. So do you do that earlier on, Dr. Anil, or you would like to defer that procedure? If your correction knee flexion is not coming up, would you do percutaneous rectus release or quads release, or
Sir,
you?
I need to do a percutaneous tenotomy rest on the degree of correction I am able to achieve at the knee. If I am not able to get 10 degrees flexion at the knee with condyles reduced, I will not go for percutaneous. I have not been successful with percutaneous tenotomies when the condyles are not reduced and there is 10-degree flexion. So I would defer percutaneous tenotomy if this is the situation.
So that means you would take an lateral X-ray of the knee joint and make sure that, or it's just a clinical thing.
It's a clinical. You can feel clinically that the condyles are reduced or not. Okay, but if there is no 10, I would ensure that there is a 10-degree flexion before doing a
Tenotomy.
tenotomy. Okay,
Okay.
usually hyperextended knees and straight knees don't respond to percutaneous tenotomy.
Right. So that's our approach also. So you start casting for the knee, and then you see gradually the increase in flexion. And many a times you can feel the femoral condyle posteriorly not reducing well. Those are the cases where you give a low profile thermoplastic splint and bring the child in a little later date, and then you do formal tenotomy or quadriceplasty. But with those patients where you see that condyles are reduced and your flexion is not going beyond 30-40 degree, you may do a percutaneous tenotomy. Yeah. And then once you have that correction, you would start either Ponseti technique for clubfoot or reverse Ponseti. But the syndromic casting techniques, they do not, they are seldom successful, and you might have to go for surgical intervention. And coming to this developmental dysplasia of hip, my approach, or I learned it from Dr. Sandeep Patwardhan, that one, we must see whether child has a walking potential. So when you see a child having cruising with this foot and knee corrected, that means they have walking potential, and then it's fun operating their hips. Many a times they, with very severe affection, they do not have walking potential. There is no point in putting those hips back. So there I take that decision later. So let's see what we did in this case. Yes, Ashwin, you can move ahead. Any question, then let us know in the chat box.
Okay. So we went for serial plaster for bilateral congenital dislocation of knee and congenital vertical talus, which were performed in intensive but unsuccessful. Then we go for quadricep plasty on right side and quadricep tenotomy on left side for congenital dislocation of knee, and talonavicular joint reduction and care fixation and Achilles tendon tenotomy on his left side at age of 9 months.
So at 6 months, we did the quadricep plasty. We got correction only 10-20 degrees, and I was not very sure that this joint was reduced. So we just gave a splint. And at 6 months, when child was big, we went on doing surgical correction. And once it got corrected, we went on for the foot correction. Yeah.
So after 10 months of first surgical intervention, he underwent anterolateral open reduction for developmental dysplasia of hip and as well as bilateral peroneal tendon lengthening with calcaneocuboid capsulotomy for congenital vertical talus. After that, he was in regular physiotherapy.
So again, Anilji, what happened? The child started cruising at 1.5 years probably, and we did open reduction for the hips, and then their feet was a bit everted, so and only passively correctable to little lesser extent. So we did peroneal lengthening and lateral capsulotomy. And with the DDH cast, we applied the plastering inversion and in more corrected position.
So what is your age for quadriceps plasty?
Age for?
Quadriceps plasty.
I
Hello.
tend to do at around 6 months. I have done the earliest. Now here on one side, the foot was more supple coming to 45 degrees. So I did just percutaneous and I reached to 90 degrees. So I was happy with it. And on the right side, it was not coming up, it was only 10 degrees. So I did quadriceplasty at 6 months. Now there are families who are tolerant with the bracing, and they can wait till 9 months. But this family was very eager to get things corrected. And in 6 months, child didn't have any health issues, so we went in. Do you do this thing earlier or at or a little later date?
Plasty I tend to do at usually I have not done before 8 years, 8 months of age.
In this case, we did it at 6 months.
And my experience with quadriceps plasty is somewhat not that good. If the child is syndromic, then the knee doesn't give very good results. Although you are able to reduce the condyles, but knee movement is an issue with quadriceps plasty.
The aim should be to flex the knee at not more than 90 degrees so that they can sit in a chair in future, because more flexion you achieve, you may lose extension.
Yes.
So I agree. So the end result is nice. That's what we need to explain. If we can achieve 90 to 100 degrees of passive knee flexion, then that should be fine. Okay. So at around 1.5 years, the foot was not, even though there's a bracing and therapy and all going, the child's foot was everting. It was kept on everting. So at one more point, we did lateral release. On the first go, we did just the medial open, mini open reduction. So I thought that the lateral structures were not addressed at that time. So let's do that, and that will solve the issue. So, and patient was very compliant with the physiotherapy and splinting. So let's see what happens next. Yeah, Tashveen?
At 3.5 years of his age, he presented with left foot eversion deformity with hind foot valgus, middle longitudinal arch obliterated, midfoot abducted, and forefoot pronated. And at 3.5 is clinical picture.
Yeah, so as you all can see, heel is in valgus more on the left than the right. And many a times you see overlap of the toes, the hallux valgus. And bolo. And so this is a problem. The child tends to be a weight on the medial border of foot. The lateral border remains everted and off. Yeah. And can you show the x-rays?
Yes, sir.
So this is how the toes are going. And family is not very happy. So on right side, the talus looks well reduced and aligned. But on left side, it has gone back. So it is recurrence of vertical talus, and these are the x-rays. So Chinmay or anyone, how would you treat it now? So it has recurred and then lateral release were done. It has recurred again. Anyone would take this call, how to treat a relapsed vertical talus?
So now we have to go for the surgical intervention through three incision techniques, sir. We have to release everything from laterally, medially, and posteriorly, and try to align the talus with the navicular and pinning.
Okay. So you mean that there is a reopen reduction. So earlier we have done
Yes, sir.
open reduction of talonavicular joint. We have done open release of lateral structures. We did percutaneous lengthening. Here you can see this calcaneal alignment is not too bad. Yeah, calcaneum is fairly the equinus is not too severe, but still the talus is going down. Can you appreciate that, Chinmay?
Yes, yes.
So, a repeat open reduction. Anything else? So Sujit is saying Grice green for recurrence. So you mean a talonavicular fusion? Is that right, Sujit?
Extraarticular subtalar arthrodesis, sir. Just put
I
a
mean,
fibula strut under the talus.
he is just 3.5 years old boy. So I would resort that later. You know, many a times if your reduction is not good, you are not able to achieve good reduction. We do talonavicular fusion in corrected position. So many a times we need to shorten this, you know, the medial border. But the subtalar fusions, Grice green, we consider in adolescent, at 3.5 years. So how many of you would go for a repeat open reduction, and how many of you would like to do some other procedure? Yeah. So Tashvin, go ahead and see what we have done,
Yes, sir.
and then we'll discuss that.
This is his gait video at 3.5 years.
Yeah. So although we have reduced his hips, we know that they have weak glutes, and they have a bit of amyoplasia, and they keep on lurching. But he's going to, I mean, at this point, he's going to school, and so he's doing well. Yeah, go ahead.
So what would be the plan? And there is a journal published in Journal of Pediatric Orthopaedic in 2023. They showed that recurrence after the initial surgery, minimal invasive method, there is a 67%. And they avoid the salvage procedure and apply revision surgery. And they told that there is a revision surgery, there is a repeat casting, primary talonavicular joint pinning, and Achilles tendon tenotomy first. Second is soft tissue release. Third is open reduction and talonavicular capsule release, and tibially center transfer to talus of the knee. But after that, they also showed that there is a radiologically it recurrence after revision of surgery. So, and they also showed that syndromic congenital vertical talus is more difficult to treat. So, to treat that with ANC, they showed the tibialis anterior transfer to the neck of the talus. And there is another paper published in Foot and Ankle International that studies suggest less than one-third of syndromic CVT patients experienced a radiographic recurrence of talonavicular deformity, with 15% requiring further surgical intervention at average of 55 months. So we what the procedure performed, that is lateral peritalar soft tissue release, open reduction of talonavicular joint and cuboid fixation, tibialis anterior tendon transfer to neck of talus, and tibialis posterior tendon advancement.
Yeah, you just finish the case, and then we'll discuss this surgical procedure.
And after 1 and 5 years follow-up, these are the picture. And And this is the radiograph.
So as we can see that now we probably have achieved the radiologic correction, and still there is hindfoot is going into a bit of valgus, and these children are at risk of recurrence, relapse. So we have to keep their lateral structures stretched. These are part of amyoplasia where their inverters and plantar flexors are very tight and short. And so we have to keep an eye on them. So coming to tibialis anterior transfer, the purpose is you are shifting T-band insertion from medial cuneiform to the neck of talus, and that T-band is holding the neck talus up, and it prevents it from falling down. So we do the same way as we do in clubfoot. We make a small tunnel through the anterior part of talus. Many a time T-band is very short, and you might just do suturing with the osteoarticular periosteal flap. And in this case, I remember we could drill it and make a tunnel and fix it with a button at the sole. So this is the second part before doing any bony fusion procedure. In young children with relapse, one can do a release procedure and T-band transfer to maintain the correction. The family is okay with it. They are happy with the shape. What I have found, the hallux valgus and the toes are gradually getting corrected. Heel is still in valgus, but there is no pressure areas or callosities along the sole. So it's probably well balanced at this point. But of course, it needs orthotic support and therapy. So there's one method. Now, if this gets relapsed in future, then it will need probably some fusion operations. There was one question about, any question. The question from Sujit was how to do quadriceplasty. Quadriceplasty we usually go with the dorsal approach. We have known a few alternate approaches like lateral approach with Dr. Sheetal Parikh explained, and do quadriceplasty where there is less skin problem. And one is to do just open the distal part of the thigh and the front of the thigh and do the release at the distal end, and you don't disturb the proximal. But my approach has been dorsal approach so far. Yeah. And Meet is asking, should the approach for index surgery CVT in age less than a year differ in an AMC versus vertical talus? What I feel is, in AMC, the lateral structures are so rigid that you might end up doing lateral releases also. And just doing mini open reduction would be under too much of force. And the moment you remove the wire, the lateral structure will still pull the forefoot in the eversion. So in arthrogrypotic children, what we try is by doing couple of casting, we try to stretch the everters, and if you cannot completely radiologically correct talus, you should do the lateral release. It doesn't take much time, and what you need to do is mainly the calcaneocuboid capsule and peroneal lengthenings, and that will resolve your issue,
Sir,
So there we do a dual approach. Many a times we do that for talonavicular, I do medial approach. For lateral release, you have a lateral incision, and the tenotomy, you do posterior approach.
Sir, while you do the tibialis anterior to the neck of the talus, post-op casting will mean more of a dorsiflexion or in a neutral position, sir.
Yeah, so you just apply in the same way as you apply in the vertical talus mini open reduction. Not much of the dorsiflexion. Keep it in neutral and a bit of inversion, because there we have fixed the wire. and you have to keep the lateral structures stretching. So to give it in a little bit of inversion.
And for total 6 weeks.
Yeah, 5 weeks. That's what we do usually now. So 5 weeks cast and then bracing and exercises. So radiologically, it's fantastic, but clinically we see the child has still weak. The gait is what do you say? Abductor lurch is there because glutei are weak, and the foot is still looking a bit everted. So that if this remains and if this progress, then the next step would be to do a talonavicular fusion and to hold this thing straight. Okay, so any other questions, or we can wind up today's session, and maybe some other time when Dr. Vrisha Madhuri is ready, we can discuss vertical talus principles again. So if there is no question, thank you very much, everyone.
Thank you, sir.
And thanks Tashveen and Chinmay for presenting nicely.
Thank you, sir.
We'll see you next week. Okay, take care.